All right, welcome back, guys. So today we're going to talk about start to talk about the skull projections in chapter 11. So let me go ahead and bring up the PowerPoints here. All right, chapter 11. Here are the objectives. So before we get started in actually talking about the projections of the skull, we first need to go over some of the kind of considerations for positioning of the skull. Some important things you need to remember when you're positioning the skull. That way you can better position the patient. First thing we need to know is we're going to talk about is the skull morphology or different types of skull that are in all humans. The average size skull, which you'll normally see, would be the mesocephalic skull. So that is the term for an average size skull. And the way to determine the size of the skull or the morphology of the skull is they look at the width of the skull versus the length, and they compare the two, and then they see what percentage of the length does the width take up. So if we're looking at the image here, right, we see that the skull on the left-hand side of that picture, 15 centimeters, is the width of the skull, right? And the width is measured from the parietal eminences, which is the bumps on the side of the head, which would give us the widest portion of the skull. So from there to there is where it's measured. Okay, that's the width, and then the length is measured from the frontal protuberance, right, and then it goes to the external occipital protuberance. So from here to there is the measurement they take for length. Okay, so then they compare the two, and if the width is 75 to 80% of the total length, then it's considered an average size skull or mesocephalic. Now, if it's more or less than that 75 to 80%, then there's two other terms of skull, which are brachycephalic and dolichocephalic. So if you look on the left there, the brachycephalic is a more wider skull. So the width you see is a little bit more than the average skull. So the width is going to be 80% or more of the total length of the skull. Okay, which means that the width, again, draw it here, the width here, right, is 80% of that total length. All right, now if that's the case, then you have a brachycephalic. The last type of skull is the dolichocephalic, which is a more narrow, longer skull. So if you notice there that the length is a lot more than the width. So if the width is less than 75% of the length, then it's considered a dolichocephalic. Important thing for you all to remember is just the name for each type of skull. So if I say average size, mesocephalic. If it's a wider skull, right, it's going to be a brachycephalic. If it's a longer, more narrow skull, dolichocephalic, right? You don't really necessarily need to remember the exact percentage or length of each skull, okay? Next, we need to talk about body planes and landmarks. Now, all this information can be found in your book, starting on page 405, and we're kind of going through the next several pages in there. So if you want to, look along, you can. Starts on page 405. Next thing is body planes and landmarks. These are very important for all of our projections of the skull because they help us to determine how to position the patient correctly, where to find centering points, making sure there's no rotation, no tilt of the skull. So all that's going to be very important when we're positioning. So we need to make sure we understand and know where these body planes and landmarks are. So if you look there, going down just the midline of the face there, the first thing you see is the glabella, which is right between the eyebrows. Right, so you notice there, that's the glabella, very important positioning points. We need to remember that. Then you go down a little bit inferior, the junction of the nose and where the forehead meets is going to be your nasion, right? I have my cap on, but kind of right here would be your nasion, all right? You go down more inferior, and where the junction of the upper lip meets the nose, it's called the acanthion, right? And then finally, the tip of the chin is called the mental point, all right? There's also, if you look on the right-hand side there, we have the supraorbital groove, which is that kind of indentation right above the eyebrow. So if you kind of start on your eyebrow and then go up, you can feel it kind of dent in. That is your supraorbital groove, all right? Then right underneath there, you have the superciliary ridge or the arch. Right? And then moving down, you have the angle of the skull, which is, or the mandible, right, which is down here, okay? So here would be your supraorbital groove. Right, superciliary ridge is kind of where the eyebrow is. Okay. Also, you see there's something called the interpupillary line. Right, now that line is an imaginary line that goes through the midlateral margin of the orbits. That is a position line that's going to be very important when we do our lateral positioning. okay? So you need to, understand where these are and just memorize where they are on the body. Now, if we look at a lateral view of the body here, we see on the front part there of the face, we can see the glabella, the nasion, the acanthion, the mental point, everything we pointed out earlier in the last slide. Then you have the angle or the gonium, right? Now, this one focuses more on the ear, right? Now, when we look at the ear, the little flappy part here on the back, right? It's called the auricle or pinna. That's all cartilage there. Then you have a little cartilage piece that that protects the EAM, right? So this little portion there, right, that's the tragus, right? Now, we all know, right, that the middle portion here is the EAM, or the external auditory meatus, right? And that tragus helps protect that EAM a little bit. Now, the other important thing to remember is the TEA, or the top of the ear attachment. Okay, that's going to be very important because that kind of corresponds to the highest level of where the petrous ridges are going to be, okay? Right? Some other landmarks of the orbit that we need to make sure we understand is the supraorbital margin. Now, when we look at the supraorbital margin, what I want you to do is take your thumb and kind of put it on the inside of your eye, right? And the inside of the eye there, which is, if I can show you the skull here, right? This inner portion here is the supraorbital margin. Then we have the infraorbital margin, which is the bottom, right? So supraorbital margin is the very top of the inside of the orbit. Infraorbital margin is the very bottom, or the bottom inside of the orbit. Then we have what's called the midlateral orbital margin, right, which is just right in between each orbit. Right? Those are going to be very important for our positioning lines also when we start looking at how to position for PA and AP projections. The canthi that you see here, which is where the junction of the upper and lower eyelid meet, those are called canthi. You have an outer canthus and you have an inner canthus. Right? Obviously, the inner canthus is where the junction of the eyelids meet on the inside. Outer is where the junction of the eyelids on the outside. So just some more terminology for you to know. All right, now here we go. This is kind of like the bread and butter for positioning of the skull. There are positioning lines that we need to know and we need to memorize, and we need to understand where they are in order to position correctly. All right, so the first thing we're going to look at is the AML. Right, I was going to read down the bottom where the bullet points are. So the AML is the acanthomeatal line, okay? And that comes from the acanthion down to the EAM. So everything is going to meet up at the EAM, right? So again, from the acanthion, I'm going to make it a different color. Make it yellow. All right, so from there to there will be considered the AML, all right? The acanthomeatal line. Then we have the lips meatal line, which comes from the junction of the lips when they're closed down to the EAM. All right. Next, we have the mentomeatal line, which goes from the mental point of the chin down to the EAM. All right. The GML, which is a glabellomeatal line. I'm sorry, yeah, the glabellomeatal line, which goes from the glabella, which is that spot in between the eyebrows, right? So it goes from there down to the EAM. Right. And then these next two are kind of the ones that are going to be used the most, right? Now, all of them are important, but these two are the most that are going to be frequently used. First one is the OML, which is the orbital meatal line, which goes from the midlateral orbital margin, right, which kind of looks like the outer canthus, from there down to the EAM. Okay, that is one that's going to be used probably the most. Then the other one is the infraorbital meatal line, which goes from the bottom of the orbit, right, infraorbital, to the EAM. Okay, so, and one thing you have to remember between these two here, the OML and the IOML, is that there is a 7 to 8 degree difference between them. Okay, so again, 7 to 8 degree difference between them. So if we look at the angle from there to there, 7 to 8 degrees. Okay, and that becomes important later on whenever we're positioning for certain projections. Other thing is, remember the alternate name for the IOML, or the infraorbital meatal line. It's the Reid's baseline. You may hear that later on in a question or something, or on the registry, they may say it's Reid's baseline. They're referring to the IOML. Okay. So again, make sure you go over and look over all these positioning lines. Make sure you understand where they're going from the acanthion to the EAM, from the orbital mid-orbital margin to the EAM. That's the OML. Make sure you understand these fully. All right. The book also talks about some skull positioning aids that may help you when you're positioning for the skull. Normally, a straight edge is pretty important to help us to determine where lines are and then if they're, perpendicular or parallel to the image receptor. So usually a straight edge. If you want to use an angled ruler like they show there, you can. Normally, like if you carry like a note card in your pocket or use your pin as a straight edge, that normally works pretty well as well. Okay. All right. Some more positioning and technical considerations. Again, we are moving along from page 405 right now. We're on page. This would be page 408. Okay. So we look at erect versus recumbent position. So there are advantages to each of these, right? Erect is generally the best position we want to get the patient in, normally because it's one for patient comfort, right? If there's injury to the head, we don't want them laying on it or putting pressure on it. The other thing is for air fluid levels. So sometimes with a trauma to the skull, you may get some internal fracture, some basal skull fracture, and then you can have fluid leaking into some of the sinuses of the skull. So in order to see that air fluid level, the best position for the patient would be an erect position, right, using a horizontal beam. So the erect can have its benefits. Now, if the patient cannot stand up and cannot, standing on their own, cannot sit up, then we will do it in a recumbent position. It can be done either way, but the erect is the preferred position. KB range you'll see for all projections of the skull somewhere between 75 to 90. So it normally doesn't go above 90 kbp. Minimum SID is 40 for all projections of the skull. There shouldn't be a reason why you need to go more than 40 inches. Small focal spot for better detail. And then, of course, since we're doing projections of the skull, we're nowhere near the gonads. We need to make sure we are shielding the patient. And that should be something that is done on every single patient for every projection, unless the shielding gets in the way of the anatomy. So you need to start practicing that as shielding every patient. It doesn't matter age, it doesn't matter what projection you're doing. Again, try shielding on every patient. All right. Now let's look at the common errors that are associated with projections of the skull. There's usually 5. We have rotation, tilt, excessive flexion, excessive extension, and incorrect CR angle. So rotation and tilt are probably going to be the biggest errors that you have, and you need to understand how rotation and tilt work. All right. So this is the projection of the skull. This is the skull here, right? So the skull sits on top of the spine, which is down here, right? So rotation means you're going to be rotating around the spine. All right. And then tilt is you're going against the spine, right? So my head here, right? If you look at my head, if I'm going this way, I am rotating. If I'm going this way, I am tilting. All right. So those are the common errors that you're going to see. The other one is excessive flexion or extension. Of course, flexion, bringing the neck down, extension, bringing the head back. All right. And then the last one you'll see is incorrect CR angle, which happens quite a bit. Okay. Biggest thing for you is understanding the difference between rotation and tilt. Next, we'll talk about a PA projection versus other projections, parieto-canthal projections. So for PA skull projections, what we're looking for is we're making sure that we are looking for any of the anatomy that's kind of in the anterior portion of the body. They want you to know that when you do a PA projection, you're going to see certain structures that are going to be obscuring other structures. And there are different variations of PA projections that we can do to move structures around. So for a straight PA projection with no angle of the CR, what you'll notice that the orbits of the patient will be filled with bone, right? So if you look here, right, these orbits, they are filled with a bone inside there. And that is the petrous ridges or petrous pyramids inside the orbits. So on a straight PA projection, right, with no angle of the tube, nothing done, you're going to have the petrous pyramids or petrous ridges filling the entire orbit. Now, it doesn't give us a good view of the orbits, but it gives us the best view of the frontal bone, okay? But there are, again, variations of PA projection that we can do to help move those petrous pyramids and ridges away from the orbits. All right, we'll talk about those later. They also wanted to talk to you about the parieto-canthal projection, which is also known as the Waters projection, which is this one here. Right, so for this one here, the main purpose of doing a parieto-canthal projection is to view these maxillary sinuses. All right. Now, in order to get those maxillary sinuses free and clear of anything, which are mainly free and clear of the petrous pyramids, which are here, we need to adjust flexion and extension of the head. So it's showing you by extending the head, you can actually move petrous pyramids down below the orbits and other structures. So we're going to use these techniques as far as flexing the head, extending the head, using a different usage of different angles in order to help us move different structures out of the way. Okay, and we'll go over all this. It's just there's a lot of information, but we'll go over all this in time. Okay. All right, another look at PA versus parietocanthal and the positioning lines and how they're going to change, right? So this should be actually flip-flop. The PA is actually the one on the right side, so I don't know why it's like that, but this PA projection should be this one over here. So what you'll notice is that the OML, remember, is one of our positioning lines. That goes from the orbit to the EAM, right, which is this OML, orbital meatal line. That is going to be perpendicular to the image receptor. Okay, that's how you position a PA projection. All right, when we look at the parietocanthal over here, we notice that the extension and flexion of the head has changed, and in particular, the extension of the head, because now we're putting the MML, which goes from the mentum to the EAM, right, the mental meatal line, is now perpendicular to the image receptor. Okay, and this would be a Waters projection, right? And that helps move the Petrus pyramids, which are here, away from the orbits and away from the sinuses. See how it moves it down? All right. If we look here, here's my Petrus pyramids, and they're going to be right in where the orbits are, right? And we know in a PA projection, those Petrus pyramids are going to fill that entire orbit. Okay. But if we just extend the head like we did over here in the Waters projection, right, now we have those Petrus pyramids moving below the orbits and below the sinuses, right? So kind of moving them out of the way. And that's kind of what they're showing you when we do different projections and a positioning of the patient, how it's going to benefit us. All right. Going back to erect versus recumbent. So remember, with all trauma projections, most of those, I mean, majority of them are going to be done recumbent with trauma, because they can't move. And most of the time, if they come in with a real serious trauma projection or a condition, they're not going to be able to flex or extend the head. So you're going to have to adjust your maybe angle, centering point to accommodate for those trauma projections. And we will go over some trauma projections of the skull from chapter 15, and I will include them in this section of the PowerPoints for chapter 10. So I'll just incorporate whatever trauma projections we would have learned in chapter 15. I'll put them into our PowerPoints for this chapter, for chapter 11. All right, again, erect position, make sure that you understand that we do erect positions in order to show any air fluid levels whenever there's been severe trauma to the skull. And the other thing is that it's easier for hyperstenic patients. So a lot of times you get a big hyperstenic patient, you try to lay them on the table. If you have to do something with them prone, what's going to happen when you try to get their head up against the image receptor, right? Their body is going to prevent the head from getting close enough to the image receptor. So you're going to have this big space between the table and the head. So in order to kind of help that out, if you do them in the erect position, we can kind of adjust them to get that head closer to the image receptor while keeping the body away, okay? Now, if it can't be done erect, again, just do it recumbent and do your best to try to minimize that OID. All right, so now let's get into positioning of the cranium, right? So here we go, bread and butter, the good stuff. So here's the routine that we're going to be talking about today. First one is an apiaxial town projection. And yes, you do have to know the alternate names for these projections, because they will be either called apiaxial skull or a town projection of the skull. Okay, but apiaxial town. The other routine would be a lateral, right? Then we do some sort of PA axial, right? And there's two versions. There's a PA axial 15 degree, which is known as a Caldwell, and then a PA axial 25 to 30 degree, which is just a 25 to 30 degree. So Caldwell is only a 15 degree angle. Okay, so anything more or less than the 15 degree, it's no longer a Caldwell projection. Right, and then we have a PA 0 degree, right? And that's just a straight PA. When it says 0 degree, that means there's no angulation of the tube. All right, and then the last thing is a special projection, which is the SMV submental vertex. All right, now remember, SMV tells you where it's a projection, so it's telling you which way the beam is traveling, right? So it's traveling submento vertex, right? Which means submentum, it's coming below the mentum, right? And exiting the vertex. So below the mentum, right? And exiting the vertex. So there, in order to position that, we're gonna have to put the skull like this in order to go below the mentum, exit the vertex. Okay, so that's one projection called the SMV. All right. All right, so let's talk about the apiaxial town method. All right, now This projection is done primarily to view the occipital bone, right, which is the bone towards the back here, right? So we want to view that occipital bone, the back of the head. It's also done to see other fractures, and there's other parts of the anatomy that we're going to see when we look at the radiograph, okay? But primarily it's for the occipital bone, the foramen magnum, and the dorsum sellae. KVP is 80 to 90, 40-inch SID. Put the patient either erect or supine. The book shows you here that they're doing them supine, which is fine, all right? You want to make sure that the mid-sagittal plane, all right, make sure that that mid-sagittal plane, right, is to the middle of the table, all right? And now when we put the patient down there, we want to make sure that we flex the neck or depress the chin to bring the OML perpendicular to the image receptor, right? So again, this positioning line here, right, it goes from the mid-lateral orbital margin to the EAM, that is known as the OML. It's going to be perpendicular to the image receptor, which is down here, right, underneath the table. We want that to be perpendicular. All right, so you're going to have to flex the neck in order to bring that OML perpendicular. All right, you want to make sure there's no rotation, no tilt. All right, so here's my skull, right? Patient's laying down. We're going to flex the head, right, to bring the OML perpendicular. Okay, so we want that OML, which goes from the EAM, right? That line there, so I can get the line there, right? That line there needs to be perpendicular to the image receptor. So adjust the head so that it's perpendicular to my image receptor, which is underneath. Okay. Now, if the patient cannot fully depress their chin to bring the OML perpendicular, you can do it with the IOML perpendicular, which is this line down here, right? Goes from the infraorbital margin to the EAM, right? So that line can now become perpendicular to the image receptor. So again, if the patient cannot flex to bring that OML directly perpendicular, we can lessen the flexion to bring the IOML perpendicular to the image receptor. Okay. Now, if we do that, we have to remember that there is a 7 to 8 degree angle difference between the OML and the IOML, right? And that's going to be important for the rest of our position. So if we have the OML perpendicular like we have in the big picture there, we need to angle our CR 30 degrees caudad to that OML, right? So if I was to extend this OML up, right, the angle between that CR and that OML is 30 degrees. All right. Now, if we get the OML perpendicular and we can angle 30 degrees caudad, we're going to center 2.5 inches above the glabella, right? So we find the glabella, right, and we go 2.5 inches above the glabella, right? Normally, for most patients, it's going to be where the hairline is, but don't take that for every patient, right? Because some hairlines go higher, go lower, some don't have hairlines. So just pay attention to the 2.5 inches above the glabella. Find that centering point. Collimate to the area of the skull, right, to include the vertex, and then you also need at least to get to the mandible, okay, to make sure you get enough of the skull, right? And then you're going to suspend respiration. So all projections of the skull are going to be on suspend respiration, all right? Now, that's if the OML is perpendicular. What if you can't get the OML perpendicular? Well, then we're going to use the IOML. Okay, now remember there's a 7 to 8 degree difference between the IOML and the OML. So if there's a 7 to 8 degree difference, how much do you think we have to increase the CR by? Right, by 7 to 8 degrees, which we are going to increase it by 7 to 37. So if you look at the bottom picture here, right, we have the IOML perpendicular, right? So if I extend this out. So now the angle between the CR and the IOML should be 37 degrees. Now, that's important because we want to maintain the 30-degree angle between the CR and the OML like we did in this picture. So if I was to extend this OML out, right, this angle between the CR and the OML would still be 30 degrees. Okay, so that's going to be important. We want to still maintain a relationship of 30 degrees between the CR and the OML for correct positioning, right, in order to see certain anatomy. Now, we adjusted to 37 because we couldn't get the OML perpendicular. So now we got to go to 37 degrees because we had the IOML perpendicular. All right. You still center at the same area, 2.5 inches above the glabella, and collimate, suspend respiration. Okay. Now in your book, there are some notes at the bottom there, right? Page 413. And the notes just basically talk about what I just told you. If you can't get the OML perpendicular, what positioning line are we going to use instead? We use the IOML, right? How much difference is there between the OML and IOML? Degree difference, 7 to 8, right? Which means that if we want to maintain a 30-degree angle between the CR and the OML, but we're using the IOML, what do we have to do to the CR? We're going to increase it 7 degrees, go to 37 degrees, right? Still centered at 2.5 inches above the belly, right? Now, which portion of the skull does this best visualize? Again, the occipital bone, okay? All right. Now, here's what it should look like. Now, let's go over the kind of the evaluation of it and what we should see. So again, primarily we're looking at the occipital bone, which we can see back here, right? There's the occipital bone, right? And that's what we're looking at. We want to also make sure that we see the foramen magnum with the dorsum sellae projected in it. Now, the foramen magnum is right here, right? So I'm going to draw a line around it, right? So you see that little kind of darker area underneath the white, that is the foramen magnum. Okay, so let me clear this out. So that right there is the beginning of the foramen magnum. All right, just point it out so we can see it. And then inside, you'll see this structure there, right? That is the dorsum sellae. So the dorsum sellae is within the foramen magnum right there. And that's what we want to see. If you see that, then you had correct flexion or extension of the patient, and you had the correct angle. So you maintained a 30-degree angle between the CR and the OML. So that right there is because you had the 30-degree angle between the CR and the OML. All right. Now, we still want to make sure the entire skull is visualized, which we do there. We want to make sure there's no rotation, no tilt. All right. So for rotation, what we're going to look at, or for tilt, right? Tilt is the easier one. So let's look at tilt. Tilt, we're just going to look at the mid-sagittal plane, right? If the mid-sagittal plane is going this way, then there's tilt. If the mid-sagittal plane is going that way, then there's tilt, right? Mid-sagittal plane, not too hard to tell. And remember, tilt is, have it like this, it's going this way, it's tilting. Let me get it straight, there we go. Rotation is when it's going like this, okay? So for rotation, what we want to look at is we want to make sure that the Petrus pyramids are symmetrical, right? So here is one Petrus pyramid, here is the other one, right? Do they look symmetrical? Yeah, pretty symmetrical, okay? So if you see that they look symmetrical, then there's really no rotation, all right? Make sure I'm covering everything here. And then optimal exposure factors, right? Make sure there's no, make sure you have sharp lines, bony trabecular markings. You can see all those structures, okay? Now, one thing I want to talk about is this dorsum sellae within the foramen magnum, right? So obviously, if you see the dorsum sellae within the foramen magnum, you had the correct 30-degree angle between the CR and the OML, right? So you had the proper amount of flexion or flexion and the amount of angle. But what happens when you don't have the correct amount of flexion, extension, or the right amount of angle? Okay, so let's talk about that. If you see this dorsum sellae, this structure right there, projected superior in the foramen magnum, what that's telling me is that there was not enough angle of the CR, right? Or you did not have enough flexion of the skull. I'm gonna say it again. If your dorsum sellae is superior to the foramen magnum, right? Dorsum sellae superior to the foramen magnum, you had less than a 30-degree angle between the CR and the OML, which means that either one of two things happened. Your angulation was off or your flexion extension was off. All right. So again, if the dorsum sellae is superior to the foramen magnum, there was not you did not maintain the 30-degree angle between the CR and the OML. Now, this happens two ways. Either you did not have enough angulation, so you were under angled, right? Under angulation, not enough. Or you had excessive extension or insufficient flexion. Okay. Now, let me show you how that works or why. All right. So let me switch over to this diagram here of the skull. All right, we're gonna do the skull here. So let's get skull here. All right, we're gonna isolate it. All right, so I'm gonna turn my head into a lateral position there, right, just to show you. So if the OML, right, and I don't know, it's not gonna flex down, but let me show you this way. Here we go. Let me fade away this frontal bone. It's not letting me do it. Okay, we have to go back. Bear with me. Oh my God. Move this out of the way. All right, now we can fade this bone. All right. So on a normal projection, right, pretend you're the CR, right, and you're angled 30 degrees, right? So you're angled 30 degrees to the OML. So you're looking down on the patient's laying down. You're the CR looking down. All right, this is what you would see on your image receptor. You'd see that dorsum sellae, right, which is that little green, that little structure right there inside the foramen magnum. All right, now what happens if you don't angle enough, right? Remember, you're the CR looking down, right? So if you're not angled enough, you're going to come more towards this side of the patient, right? So what happens to that dorsum sellae as you decrease your angle? You see it go superior to the foramen magnum. All right, that's one way. But if you're angled correctly like this right here, right, but the patient decides to extend their head, right, they're bringing their head back, again, what happens? The dorsum sellae goes above the foramen magnum. So those two things are going to happen, and it's going to cause that dorsum sellae to go above the foramen magnum. Either you're not angled enough, right, you decrease the angle, or you decided to extend your head, right? So you extend your head, you're bringing your head back, and that dorsum sellae goes above the foramen magnum. All right. So, two ways that the dorsum sellae can be located superior to the foramen magnum is if there is not enough angle, or you had excessive extension, insufficient flexion. Okay, excessive extension, not enough flexion. Okay, I know I'm trying to help you all visualize it here because it's going to be a lot to remember. Okay, now if you see that dorsum sellae projected into the posterior arch of C1, right? And let me turn this around. Here's the posterior arch of C1. I'm going to highlight it. Right? We're going to go back to this guy. Move him here. All right. So that's normally what we should see, right? Now, what happens if you see that dorsum sellae projected onto that posterior arch? Well, there's two things that can happen, right? You either angled too much, all right, or you had excessive flexion, you flex too much, or not enough extension. Okay, so again, if you see that dorsum sellae projected over that posterior arch of C1, then that means you had too much angle on the tube, or you had more than 30-degree angle between the CR and the OML. Okay, so that's kind of the way you can think about it, and then it might help you to understand. So let me turn it this way, right? So let me draw on here. There's a control menu. What does control menu do? I'll mess with that later. Okay. So let's write on here. So here is your OML, right? There's your OML. Okay. I really can't rotate it down. So we're going to pretend like the IOML is perpendicular. Well, it's not really going to show you. But anyway, if we're angled, our CR is angled right this way, right? We still want to maintain a 30-degree angle between the OML and the CR, right? That's going to give us the perfect projection. Anytime you have less than 30-degree angle, right, then you're going to get that dorsum sellae projected above the foramen magnum. Two things can happen, right? Either I bring the CR this way, right, I decrease my angle, it's going to cause the dorsum sellae to go above the foramen magnum, or if I move my chin up, right? If I bring my chin up, then this positioning line here, right? This positioning line there now goes this way, right? And now you have a positioning line maybe here. You've decreased the angle here, right? It's not no longer 30 degrees. So either by extending the head or decreasing the amount of angle, that dorsum sellae goes above the foramen magnum. All right. Now, going the other way, right? Again, here's my OML, right? Here's my 30-degree angle. Now, if it's more than 30 degrees, then that dorsum sellae goes below the foramen magnum and it gets superimposed over that posterior arch. Two ways that can happen, right? Either I move my angle this way, right? So this here again is 30 degrees. Right? If I move my CR, oh, what the, hold on. I hit the wrong button there. All right, so if let me move this out of the way. So again, if I move the CR this way, this thing's going crazy. So I move the CR this way, right? Now I've increased my angle, and it's going to be more than 30 degrees, right? But how else can I increase the angle between the CR, which is right here, and the OML, which is right there, right? How else can I increase that angle? Well, if I bring the head down, right? If I bring my chin down, does it move this positioning line this way? It does, right? And then what happens to the angle between there and the positioning line, right? It goes more than 30 degrees. Okay, and that's going to again cause the dorsum sellae to go below the foramen magnum. All right, I know it's a lot of stuff to try to remember. All right, and I'm trying to get you to try to help you visualize what it looks like, right? So that again is what we want to see, right? Perfect 30 degree angle between the between the CR and the OML. If there's too much angle between the CR and the OML, it goes like this, right? If there's not enough angle, like that, there's not enough angle between the CR and the OML, right? Then it goes like that. Okay, so again, good, too much angle or too much flexion. Right here, not enough angle, not enough flexion. All right. So if you need to, right, then you can kind of pause this or go back and kind of write down notes. Make sure you understand, you know, how do I get my images to look, you know, either with the foramen magnum too high or too low, right? What's going to cause that, right? And that's what you kind of need to write down. Okay, so that was AP axial. Again, we're trying to visualize the occipital bone, but we also want to see the dorsum sellae within the foramen magnum. Okay. Lateral skull. So with the lateral skull, this kind of gives you a general overview of the entire skull. So we're looking at kind of all the structures, all the parts of the skull on this lateral, right? It's not the best for any one thing, but it shows you everything. So we're also looking for fractures, good for air fluid levels if we need to see air fluid levels. KVP 75 to 85, 40-inch SID. Erect or semi-prone, which, well, again, erect is the most preferred, but if you need to do it prone, then you can for patient comfort or if they can't stand. Put the head in a true lateral position, right? So this is going to be important here is to get this head in a true lateral position, right? And there are a few ways to, or a few things, positioning lines that we need to look at in order to get that in a true lateral position, all right? So what I'm going to do is see if I can draw this. All right. So let's pretend that this is the skull here, right? So we have the eye there, the nose there, the mouth, right? Let's try to draw the eyeball. Okay, so he looks kind of scary, but that's the guy, right? And we're trying to get this in a true lateral position. So here is my image receptor, right? I'm sorry, image receptor's underneath. I don't know why I have it there. Let me erase this. So again, right, my image receptor is behind him, sorry. All right, so there are a couple of things we want to make sure in order to get a true lateral position of the skull. All right, so first thing is you want to make sure that the interpupillary line is perpendicular to the image receptor. All right, so remember the interpupillary line is an imaginary line that goes through the eyeballs. All right, so a line there that goes through the eyeballs. Now maybe be better on this other one here. Let's try this. So if I'm in a lateral, right, I want the line, oops, the line that goes from this imaginary line that goes from there to there, right? I'm looking at that line there. All right, so keep that in mind because it's not going to save it on there. Okay, so that line needs to be perpendicular to the image receptor, which is behind the patient. Okay, so if I'm here, right, I have my patient laying down, right, in a lateral position. So I'll show you like this. They're in a lateral position. This positioning line, the IPL, needs to be perpendicular to the image receptor, which is sitting underneath the patient. All right. I'm going to take out this background, that way you can see better. Okay, so here's my guy right here, right? He's on the image receptor, which is underneath. This interpupillary line needs to be perpendicular to the image receptor, which is underneath, to the plane of the IR, right? So it's perpendicular, right? That line is going straight down to the plane of the IR. That helps to prevent from you tilting the patient. Okay, because remember, this is tilt, right? We don't want that to happen. So if we have that IPL perpendicular, if we tilt, we'll know that there's tilt because the IPL is no longer perpendicular, right? The other thing is the OML, right? And we want the OML, let me go back to my other drawing. Hopefully it's still there. Yep. We want the OML, right? We'll pretend the ear is here. All right, there's my ear. We want this OML to be perpendicular to the front edge of the image receptor. Okay, which means that there will be no rotation. I'm sorry, that means that there's going to be correct flexion extension of the patient. Okay, which means that if I have my patient like this, right, my image receptor's in front, right, I want to make sure, let me get it right there. I want to make sure that I have enough flexion extension, which means that the OML needs to be perpendicular to the front edge, right? And we can see the OML is right there, right? So that OML needs to be perpendicular to that front edge of the image receptor, right? Even though we know the image receptor is on the back, right? Here's the front edge. So it needs to be perpendicular to that front edge. So if I have my image receptor behind, right, and I just bring the edge out to become a plane, that OML is going to be perpendicular to that front edge. All right, so that's another thing. The next thing is the mid-sagittal plane needs to be parallel to the plane of the image receptor. So again, image receptor is behind, right, where I'm at. Here's the mid-sagittal plane. It goes across the body this way, right? It's a plane like a piece of paper. It's like this, right? Like a piece of paper. So it's a plane that goes through the body, mid-sagittal plane, right? That plane needs to be parallel to the image receptor that's behind. Okay, that'll help prevent rotation, right, and tilt. All right, so again, make sure that mid-sagittal plane is parallel to the image receptor. The last thing is the GAL. And the GAL, remember, is a line that goes from the glabella to the alveolar process of the maxilla. That plane needs to be parallel to the front edge of the image receptor. All right, so four things, right? And I'm trying to show you here on Zoom because it's better to show you in person, but it's kind of hard on the Zoom thing here. So let me go back to the PowerPoint. Right, and four things, right? So again, head and true lateral. You want to align the mid-sagittal plane parallel to the IR, right? IPL perpendicular to the IR. And then finally the IOML perpendicular to the front edge of the IR. I think I told you OML. It should be IOML, sorry. I don't know why I told you OML. It should be the IOML. So let me go back to this guy here. My mistake. I erased him. But anyways, it should be the IOML perpendicular to the front edge of the image receptor. Right. So again, make sure you look over these four things, right? Because you will be asked a question on how do you determine if you're in a true lateral position, right? First one is IPL should be perpendicular to the image receptor, right? The IOML, which is this line here, needs to be perpendicular to the front edge of the image receptor, right? The mid-sagittal plane, which comes this way, right, needs to be parallel with the image receptor, all right? And then the GAL, which is in the front here, needs to be parallel to the front edge of the image receptor, okay, right? So I also draw an image receptor around her like that, right? This GAL is parallel to that front edge, all right? If I also draw another image receptor there, IPL is perpendicular to the image receptor that's laying flat. All right. So this stuff here, make sure you know. All right. Make sure you know that the IOML is perpendicular to the front edge of the image receptor. The MSP, mid-sagittal plane, is parallel to the IR, and the IPL is perpendicular to the IR. All right. And then the fourth thing is the GAL parallel to the front edge of the image receptor as well. All right, so if you do all that, get them in a true lateral position, right? Have them in a true lateral position. All right, then all you're going to do is find the centering point. And the centering point is going to be 2 inches superior to the EAM, right? So you find the EAM and go 2 inches superior. Collimate, suspend respiration. Now, there's another way to find a centering point if you have something other than a normal sized skull. So if you have a dolichocephalic or brachiocephalic skull, which is a wide or narrow skull, there is another centering point that you can find besides the 2 inches above the EAM. And that is you want to go midway between the glabella and the occipital protuberance, all right, or the inion. So what you would do is you'd find the lateral, go to the skull here. All right, and you're going to go midway between the glabella and the inion, right? So here's the glabella, and there's the inion, and you'll go a spot midway between there. That is for other skull morphologies, right? As opposed to the average size skull. If it's the average size skull, 2 inches superior to the EAM. If it's other morphology skulls, midway between the glabella and the inion. Okay. All right, now let's see what it looks like here. All right, here's the lateral skull. Want to make sure you include all of the skull on there. Make sure it's all on the actual exam. You want to make sure that there's correct exposure factors, which is sharp lines, monotrabecular markings, making sure you can see everything. Now, we need to determine if we have rotation or tilt, right? And so there are parts of the anatomy on the skull that we can look at in order to determine if we have rotation or tilt, right? So first thing for what you need to know for rotation is you're going to see anterior posterior separation, which means if I have my items like this, right, they should be superimposed. But if I have anterior or posterior separation, then that means I had rotation, okay? Which means that my skull was sitting like this, right? And you saw two structures in there supposed to be superimposed. If I rotate the skull, right, let's go this way, rotate the skull, you'll see structures move within the skull, right? There'll be anterior, posterior separation. Then that means you have rotation, right? The first structure you should look at for rotation is the mandibular rami, which are these structures down here, right? So we're gonna look at the mandibular rami. If they're rotated, you're gonna see one on each side, right? So let's go back to this guy here. Isolate the skull. All right. So if I'm in a true lateral position, right, you can only see one mandibular rami down here, right? But if I rotate, what happens? You start to see the other one, right? So there's rotation. So anytime you have anterior, posterior separation, right, one coming forward, one coming back, you're going to have rotation, right? Tilt is a different story. Tilt is going to be superior, inferior separation. So if I have something in the skull like this, and I tilt, one will come higher than the other, one will go lower. Okay, so anterior, posterior separation is rotation. Superior, inferior separation is tilt. Okay, so let's go back to the PowerPoint. There we go. All right, so there are some structures that we need to pay attention to, right? So for rotation, we want to look at the mandibular rami. So the rami, which are down here, right? If we only see one, then we're good. There's no rotation. If you see anterior, posterior separation, then you have rotation. Other thing we want to look at is they're called the greater wings of the sphenoid, right? And they're located right in there. You see two lines, one going up, right? One going up there, and then one going up there, okay? Those are the wings of the sphenoid, greater wings of the sphenoid. Why isn't it erasing? Oh my God, what did I do? Hold on. There we go. All right, so again, mandibular rami, greater wings of the sphenoid, right? The other thing you can look at is the sella turcica, which is right there, okay? And if you see the dorsum sellae, which is the posterior part here, right? If you see two, right, because they're supposed to be superimposed like this. If you start to see one structure in front of the other, then you have some rotation. And the last thing would be the EAMs, which would normally be about right there. And you'll see two holes there. If you start to see one hole in front of the other, then that means you have rotation. Okay, so those four structures, mandibular rami, greater wings of the sphenoid, sella turcica, EAMs. Okay, what's the first thing we look at for rotation? Mandibular rami. All right, keep that in mind. The first thing you want to pay attention to, right? The only one that's going to be used for rotation is the mandibular rami. These other three that we talked about, greater wings, the sella turcica, and the EAMs, those can be used for tilt as well. Okay, but the only one for rotation is mandibular rami. Now, for tilt, we're going to look for a superior, inferior separation, right? And what we want to look at is these structures here. That is called the orbital roof or orbital plates, right? At the very top of the orbits here, right? And there's two plates that sit right on top of the orbit, right? The two pieces of bone. They're supposed to be superimposed, which they are there, right? Pretty superimposed. But if I saw a line up here, right, and then this line there, then that means I have tilt because one went superior, one went inferior, okay? So that's the first structure you can look at, and that's the first thing you should look at for tilt, right? Of course, the other structures would be the greater wings of the sphenoid, sella turcica, and the EAMs, right? Because we saw an EAM there and we saw another EAM up there, then we have tilt, okay? So remember, the three structures that can be used for both are the greater wings, sella turcica, and the EAM. Those three structures can be used to determine both tilt and rotation. The plates or the orbital roofs are used for tilt. The mandibular rami are used for rotation. Okay, and then these three in the middle can be used for both. All right, a lot of things, right? So make sure you take some notes down, right? Go back, rewind this, whatever you got to do. What do I need to use, or what's the first thing I should use to determine rotation on a radiograph? And I hope you said the mandibular rami. what's the first thing I want to, or what's the one structure I want to use to determine tilt, right? What's the only one that you're going to use for tilt when you're trying to look on a radiograph? The orbital roofs or orbital plates. What other structures can I use to determine both? Greater wings, cell turcica, EAM. Okay. All right, that's your lateral. All right. So again, going back to this, here's my EAM, right? If I saw another EAM on my radiograph up there, that would be what? Tilt, right? Now, if I saw this EAM there, oops. If I saw this EAM there, but then I saw another one back here, what does that tell me? Rotation, okay? If I see two rami like that, rotation, all right? Good. Let's see. Trying to see if you can see the orbital plates or orbital roof. Kind of hard to see there, really can't. All right, never mind. Okay, so let's go back to the PowerPoint. All right. So next projection on page 415 is the PA axial projection, also known as the Caldwell, 15-degree Caldwell. So this projection here is going to be used to best visualize the supraorbital margin, right? Or the very top of the orbit. So what we're looking at here is we're going to look at the top of the orbits here, supraorbital margin, okay? Also can be used for the frontal bone, but it's not the best projection of the frontal bone because there is an angle of the CR. Okay, but we're looking for other fractures, any type of projection, pathology within the skull. 80 to 90 kVp, 40-inch SID. Again, put the patient either erect or prone. Erect is the preferred position. Align the mid-sagittal plane to the center of the IRCR. Now, for this PA projection of the skull, we want to make sure that we get the OML perpendicular to the image receptor. Okay, which means that, again, we want, get them in there, right? That OML there, right? So I can, maybe the other hand's better. Kind of hard to get this OML. So that OML there needs to be perpendicular to the image receptor, right? So what am I gonna have to do? Well, I'm gonna have to flex the head, right, to bring that OML perpendicular. Okay, so we want to make sure that we put the nose and forehead on the image receptor. That'll help bring the OML down perpendicular to the image receptor. Okay, so for this PA projection, it's going to be true for all PA projections of the skull. We want the nose and forehead on the image receptor, right, just like the patient has there, because it helps bring the OML perpendicular to the image receptor. All right. Make sure there's no rotation or tilt of the head. So you may need to go on the side, on the front of the patient, make sure there's no rotation, no tilt, make sure they're perfectly straight. All right. And we're going to angle the CR 15 degrees caudal. All right. So if you look here, right, this first one, it's 15 degrees caudal. Now it needs to be 15 degrees caudal from the OML, which is here, OML. So we're looking primarily at the relationship or angle between the CR and the OML. That needs to be 15 degrees. That's going to give us the Caldwell projection. Okay, it's the relationship between the CR and the OML of 15 degrees. All right, we're going to center to exit at the nasion. So have that light field, right, the crosshair going right through the nasion. And when I talk about the crosshair, I'm talking about the crosshair that looks like that on your, from your light field, right? Make sure that the center of that crosshair is right where the nasion is. Make sure it's exiting there. Okay. So one way to tell, right, is if you look at your crosshairs, right? So say I have my skull right? And this guy is sitting like this, right? You really can't see, right? But you know that the crosshairs go, one go that way, one go this way, right? You want that center of the crosshair to be where the nasion would be, right, on the other side of the patient. So look at the table and see where those lines are going and make sure they meet up at the nasion. Okay. Actually, you know what? Let me go back to this. So what I want you to see is that, let's isolate the skull there. So if you're the image receptor, right, you want this patient's neck flexed, so that way the OML, or you want the nose and forehead on the image receptor, okay, and that'll bring the OML perpendicular. And that's how you want this projection to be done, because you want this frontal bone to be flush on the image receptor. Okay. All right, once you've done that, you have the nose and forehead on the image receptor, OML perpendicular, you're angled 15 degrees to the OML, center to exit at the nasion, collimate, suspend respiration. All right, nothing to it. Now there is an alternative projection, right? And this is called a PA axial 25 to 30 degree, right? It's the same positioning, everything's the same. Nose and forehead on the image receptor, OML perpendicular, no rotation, no tilt, still gonna center to exit at the nasion. The only difference is now we've angled the tube 25 to 30 degrees. Okay, now what this is gonna do is this is gonna show more of the infraorbital margin. Even though it's distorted, it's going to show a little bit more of the infraorbital margin. It's also used to show the supraorbital fissures, right? You're like, well, what the heck are the supraorbital fissures, right? Let me show you. Supraorbital fissures are those structures there, all right? That's what you will see with that 25 to 30 degree angle, okay? Oh, and you'll also see, of course, what I just said. You'll see more of the orbits there, okay, the infraorbital margin of the orbits. Although it's distorted, but you'll see them. Okay, back to the PowerPoint. All right. So again, what makes it a Caldwell, right? What makes this PA axial Caldwell? I'll wait a little bit till you tell me. And I'm sure you're going to say that it's the relationship between the CR and the OML of 15 degrees, right? Because just because I angle the CR 15 degrees doesn't make it a Caldwell. It has to be the angle between the CR and the OML of 15 degrees. That's what makes it a Caldwell, okay? Because I can angle the CR 15 degrees, but if the OML is way off, it's not going to be a Caldwell, okay? Now, what does the Caldwell show? Okay, well, it shows the supraorbital margin, right? It's going to show the frontal bone a little bit, not the best projection of the frontal bone, but it shows it. And then if I want to see the bottom of the orbit, right, even though it's going to be distorted, and I want to see those supraorbital fissures or superior orbital fissures, what can I do? We just angle the CR 25 to 30 degrees, okay? Now, this is a projection of the Caldwell. It's not the best projection of the Caldwell, but it kind of shows what we're looking at. So with a Caldwell, if it's a correctly positioned Caldwell, PA 15 degree between the CR and the OML, you're going to notice that the Petrus ridges are going to be located over the lower 1/3 of the orbits, right? Which, right there. Petrus ridges are in the lower 1/3 of the orbits. Okay, that is a correctly positioned Caldwell projection. That means that your CR and your OML had a 15 degree angle between them. Okay, this projection, we also will visualize the supraorbital margin and the frontal bone. Okay. Make sure there's no rotation, no tilt. All right. So when we're looking at rotation, we're going to look at the distance between the lateral margin of the orbit and the lateral cranial cortex. So we're looking at this portion here to the edge of the head. If the distances are the same on both sides, then there's no rotation. Okay. However, if there's distance is greater on one side than the other, then you have some rotation. So let's go back to this guy. All right. So again, if I will, oops. We're going to look at just the frontal view there. So it's perfectly straight. So what we're looking at is we're looking at the distance between there and there, right? They're the same on both sides, no rotation. However, if one side is rotated more, what happens to that side? The distance on between the cranial cortex and the lateral margin. This side gets bigger, this side gets smaller. So if this is my right side, this is my left side. So if the right side, the distance between the lateral orbital margin and the lateral cranial cortex, that distance gets bigger, what happened? Well, you were rotated to the left, right? Your face was rotated towards the left, which means that if you're looking at me, right, or we'll look at the skull here, right? So we're looking at the skull, right? And this is the right side of the skull, this is the left, right? So we're looking at the right side here. So if this distance gets bigger, that means that the face went towards the left. If the left side gets bigger, the face went towards the right. So there was rotation to the right. Okay, so that's how you're going to determine if you have rotation. You're looking at the distance between that lateral margin of the orbit and the lateral cranial cortex. Okay. All right. Other thing I wanted to show you is that if you want to, again, we're looking at the petrous ridges within the orbits, right? So this right here should be able to show you. Bring this back this way. We can isolate this one. So what we're going to do is we're going to hide this, all right? And we're going to fade that one. Okay, so everybody see the orbits there, right? So my patient has their nose and forehead on the image receptor. So if you have your nose and forehead on the image receptor, you will see that the ridges, right, which are these structures here, right, they're in the lower 1/3 of the orbit. Okay, so everybody see the orbits here, right, the holes that are there, right? If we're in a correctly positioned Caldwell, that's what you will see. You will see those ridges in the lower 1/3 of the orbit, right? So if I'm here, and you're the image receptor, right? So you're looking at the image receptor. You're the image receptor, there you go, right? You see the petrous pyramids in the lower 1/3 of the orbit. Now, what happens if you start seeing the orbits move? Or, if you start seeing the petrous ridges move within the orbit? How would I get those petrous ridges to move further into the orbit? What happens to my head, right? My head starts flexing, all right? So if I start flexing my head, right, my ridges start filling the entire orbit. If I extend my head, they start going below, right? Because they're supposed to be here with the OML perpendicular, right? If I extend my head, then the ridges go below. If I flex my head more, then I get them inside the entire orbit. Okay, so that's going to be important because you have to understand the relationship between the CR and the OML. Okay, so if the CR and the OML maintain 15 degrees, where do we see the orbits? Or where do we see the ridges? We see them in the lower 1/3 of the orbit. If there is excessive angle between the CR and the OML, which means that you have more than 15 degree, then they start going below. Okay. If I have not enough angle, too little angle, they start filling the orbits. Okay. So I will talk about that more. Give me 1 second here. All right, guys. So like I was saying, you need to make sure that you understand that for a Caldwell projection, right? In order for it to be a Caldwell and for those ridges to be in the lower 1/3 of the orbit, there needs to be a 15-degree angle between the CR and the OML. If it's less than a 15-degree angle between the CR and the OML, then you get the ridges moving up into the orbits. If it's more than a 15-degree angle, then you get the ridges moving down below the orbits, okay? So the way it's gonna happen is if I have my patient like this, right? And it's kind of hard to see without me being with y'all, but here's the patient, right? They have their nose and forehead on the image receptor. OML is perpendicular. So my OML, if I bring it up, it goes this way, right? My angle is supposed to be 15 degrees from that OML. So if my OML is here, right, and my CR is here, the angle between them is 15 degrees. Now, how can I decrease the angle between the CR and the OML? Right? Now, one way to do that is to just decrease the angle. So if I decrease the angle to less than 15 degrees between the CR and the OML, right, then I have the ridges moving up in the orbits. Another way to help reduce that angle, or that you can reduce that angle, is by flexing the skull. Because remember, here's the OML. Here's my angle of the CR. If I flex my skull, now it matches the angle of the CR, right? It's decreasing that 15-degree angle between the CR, which is here, and my OML. Okay, so if you flex the head or just decrease the angle of the CR, then you'll get the ridges moving up into the orbit. Now, how do the ridges move down below the orbit? Well, that means that there's a more than 15-degree angle between the CR and the OML. Again, OML here, CR here, right? So OML is here, my CR is over here. So that angle between them is 15 degrees. Now, if I want to move the ridges down in the orbit, I increase my angle. And now I have more of an angle of 15 degrees between the CR, which is here, and my OML, which is here, all right? How else can I increase the angle? So if I'm here at 15 degrees, right, between the CR and the OML, how else can I increase the angle? Well, I need to move my OML this way, right? How can I move my OML that way? If I extend the head, right, now my OML is over here, but my CR is still over here. So is that a more than 15-degree increase in angle between the CR and the OML? Yeah, it's more than 15 degrees. So what's that going to do? It's going to move the ridges below the orbits. Okay. So those are, again, things you need to remember whenever you're positioning the patient, because it's going to be important to determine, well, what do I have to do if I see the ridges going higher or lower in the orbits? Okay. One way to do it is, here are my ridges, right? My fingers are my ridges. So if I'm in a PA position, right, a projection, and I position my patient correctly, OML is perpendicular, here's where my ridges should be with that 15-degree caudal angle. If I increase extension, they go below, right? And whenever you increase extension, think of it as I'm increasing the angle between the CR and the OML, they go below. If I decrease extension, right, now they fill the orbits, and I've decreased the angle between the CR and the OML. So again, here are my ridges in my orbit in the lower 1/3. Increase extension, I increase the angle between the CR and the OML, they move down. If I decrease the extension, then they go higher into the orbit, and I decrease the angle between the CR and the OML. Kind of maybe help you to understand or remember how to do it, or which way they go, but it just takes a lot of going back over it and kind of doing it on your own to see, well, if I increase or increase the extension or increase flexion, increase angle, decrease angle, what's going to happen? Because you have to understand where those ridges, how they move inside the orbit, okay? But Caldwell, where should they be? Lower 1/3 of the orbit, okay? Now, let's compare the Caldwell versus the PA 30-degree, right? So the Caldwell's on the left side here. There's my Caldwell. You'll notice the ridges again, lower 1/3. This is the PA 30-degree. Now, the ridges are down here, right? Here's my bottom of the orbits, right? And again, how did we get that ridges to go below the orbits? Well, we increase the angle. Anytime you increase the angle between the CR and the OML, you're going to move the ridges below the orbits or down below the orbits. Okay. So for this one here, there are those superior orbital fissures that we saw on that skull. Okay. That's what we want to see on a PA 30 degree. So remember, Caldwell, we're visualizing let me erase all this stuff. Right. The Caldwell, we're viewing frontal bone, supraorbital margins. Right. Important thing to remember, ridges are in the lower 1/3. PA 30 degree, ridges are below the orbits because of that increased angle. We can visualize the infraorbital margins and the superior orbital fissures. All right. Let's move on. All right. Now to the PA projection. This is a PA 0 degree. So far we've covered AP axial, which is the town. We covered the lateral, and we covered 2 PA projections, the Caldwell, which is 15 degree, and then the 25 to 30 Caldwell. I'm not Caldwell, 25 to 30 PA axial. This one here is just a PA projection. You don't see axial after it. So if you don't see axial, it's just a straight PA projection, no angle, 0 degree angle, okay? The KVP 80 to 90, this is the best projection for the frontal bone. Again, best projection for the frontal bone, PA projection, because it's forehead on the image receptor, no angle of the CR, there's no distortion. We're going to set up the patient like we did for all PA projections, right? What 2 structures need to be on the image receptor? Nose and forehead, right? So keep that in mind. Keep that in your memory. Nose and forehead for all PA projections of the skull. Okay, so if it's a PA projection of the skull, it doesn't matter if we're doing 15 degree, 25 to 30, 0 degree, you're always going to set up the patient the same way. Nose and forehead on the image receptor, which brings what positioning line perpendicular to the CR? I'm sorry, to the IR? The OML. Okay, nose and forehead on the image receptor helps bring the OML perpendicular to the image receptor. All right, make sure there's no rotation, no tilt. All right, CR now, this time there's no angle, so you're going to be perpendicular to the IR, but ideally you want to be parallel to the OML. Here we go. There's the OML. Here's the CR. Wants to be parallel to the OML. Now, when we do this, if the CR is parallel to the OML, right, and we know that when you decrease the angle between the CR and the OML, right, because 15 degrees will be down here. What happens when you decrease the angle? They start filling up the orbits, right? So with the CR parallel to the OML, you're going to have the ridges inside the entire orbit. Okay? You're going to center the exit at the glabella. So it's not the nasion like the PA axial projections. It's a little bit higher. It's the glabella. Okay? So again, find that crosshair on the table. Make sure one crosshair goes this way, one crosshair goes that way, and they meet in the middle of the glabella. Okay? Collimate and suspend respiration. So let's go back to this guy here. Remember we saw the ridges, which are back here, right? They're going to fill the orbits on a PA 15 degree, right? So we have the nose and forehead on the image receptor, which is below us, right? But we have a 15, you're the 15 degree angle, right? You're looking at the patient, you're angled 15 degrees. So now if we have no angle, we're going to look like that. You're going to have the ridges within the entire orbit. All right, so that's a 0 degree angle, right? This would be a 15 degree angle. This would be a 0 degree angle. All right. This is what it looks like. The entire skull visualized. You want to make sure there's no rotation, right? And again, these are my orbits filled with the Petrus ridges or Petrus pyramids. That tells me that I had a 0 degree angle between the CR and the OML. The CR was parallel to the OML. So anytime you see the orbits fill the entire, I'm sorry, the ridges fill the entire orbit, that means that your CR and OML 0 degrees, right? There's no angle between them. They were parallel to each other. All right. I want to make sure that the have optimal exposure factors, sharp lines, bony trabecular markings. Okay. And again, make sure there's no rotation, no tilt of the patient. All right, so let's compare these two, right? On the left, you have the 0 degree projection, and on the right, you have the Caldwell. Make sure you understand, you can tell the difference between them both, because you will ask some questions. You might get a radiograph that says which PA projection is this? If you see this one here, right, with the ridges in the lower 1/3, that's a Caldwell, right? If you see them filling the entire orbit, well, then that's a 0 degree. What if you see the ridges way down here below the orbits? Well, that's a 25 to 30, okay? So make sure that you can identify which projections are which, right? And again, we're looking at the ridges in comparison with the orbits. Here's a projection of all three, right? Caldwell, PA 0 degree, 30 degree PA. Okay. Which one's best for frontal bone projection? This one, right? 0 degree. Which is best to visualize which one can visualize the infraorbital margin and superior orbital fissures? This one here, right? Which one is for the supraorbital margin? And you can see some of the frontal bone as well. This one here, okay? So again, know the difference between each, know what they're used for. How do we get the ridges to fill the orbit here? Well, you need to decrease the angle between the CR and the OML, which means you're either going to have the CR with no angle, right? Or you're going to have an increase in flexion to bring that to a 0 degree angle, okay? All right, last projection that we're going to go over today is the SMV, right? Submental vertex. This one here is used to identify basal skull fractures, right? But back of the head, kind of bottom of the skull, right around here. So we're looking at any fractures down below here. Okay, that's what we want to see, basal skull fracture. Usually when you have a basal skull fracture, you may have some fluid leaking. So this one is best done erect, so we can get air fluid levels. Again, if you can't do it erect, you can do it sitting down in a wheelchair or a chair. KVP is 80 to 90, 40-inch SID. Now, this position of the patient is very difficult for the patient to hold, so you need to make sure that you have everything set up first before you do this projection. Make sure you have your tubes aligned at the distance. Make sure you have your technique set up, all that before you start positioning the patient, because they're not going to hold it for very long. So what you want to do is you want to raise the chin and hyperextend the neck till the vertex is on the image receptor. So my image receptor is behind here, right? I need to hyperextend the neck and put the vertex on the image receptor, okay? You want to make sure that when you do that, that the vertex is sitting on the image receptor, okay? Now, the positioning line that you need to pay attention to is the IOML, right, which is this line here. So the IOML needs to be parallel to the image receptor. And I think it's because this camera is kind of at an angle, you really can't see it too well. So again, here it is, right? So the IOML needs to be parallel, right? So here's the IOML, right? See if I can hold this together. That IOML needs to be parallel to the image receptor, okay? All right, once you've done that, right, you need to make sure that there's no tilt, no rotation, all right? And you're gonna have the CR perpendicular to the IOML. So here's your IOML. You want the CR perpendicular to the IOML. So it's not necessarily perpendicular to the IR. It's not necessarily perpendicular to the IR. It's perpendicular to the IOML. Okay, and that becomes important because if the patient cannot extend their head to put that vertex on the image receptor, right, what are we going to have to do? Well, if the patient has their head down like this, we're going to have to adjust our CR so that becomes perpendicular to the IOML. Okay, no longer perpendicular to the IR, it's perpendicular to the IOML. Okay, now the centering point. We want to make sure that the centering point is 1.5 inches inferior to the mandibular symphysis. So here's the mandibular symphysis. We want to enter 1.5 inches below that or midway between the gonions. Okay, so you can find a point midway between the gonions or go 1.5 inches below the mandibular symphysis, and that's where you want to center. Center under there, under the vertex, right? And then we're going to exit at the, under the mentum and then exit at the vertex. Oh, the skull's falling apart. There we go. All right, collimate and suspend respiration. Okay, so if we're looking at the skull here, right, and again, we're going to isolate this skull. All right, now this is what we want to see. Okay, we want to see this skull, kind of like, oops, like that. All right, so that's how the SMV should look. So I can turn this, I can't turn it around, but. So we want the CR to enter. All right, let me get this a little bit more straight, sorry. All right, we want the CR to enter 1.5 inches below the mandibular symphysis or midway between the gummies. So it should be at a point somewhere around there. Okay. And this is what we want to see. We want to see the bottom of the skull. We want to make sure there's no basal skull fracture. All right. We want to make sure that we see the entire skull. Right. And we also want to look at to make sure that we have no rotation, no tilt. All right. Now, rotation is going to be easy to tell, right? Because if you're like this, if the mid-sagittal plane goes right or left, right, which the mid-sagittal plane is the plane that goes down this way, right? So if you see it rotating that way or rotating that way, then you have some rotation, right? Now, if we want to check for tilt, we're going to check the distance between the mandibular rami and the lateral portion of the skull, right? So the mandibular rami, lateral portion of the skull. I want to make sure that those two distances are the same on each side. If one gets bigger than the other, then we have some rotation, right? So again, we're looking at the distance from the mandible to the lateral portion of the skull here. So this distance right in there, right? So that little distance. So if this distance gets bigger, right? Because here's the skull, here's the mandible. If that distance got bigger, right? Then what happened? Well, the vertex was tilted to the right side. Okay, because this is the right side here, right side of the patient. So again, if the distance on that one side gets bigger, then the vertex was tilted to that side. All right, so if we're looking here at the patient, here's the right side, here's the left side. So if we see this side getting bigger, what does that tell us? That means that the vertex was tilted to the right. And remember, it's tilted, not rotated. Okay. All right. Other thing I wanted to show you. How can we tell if we have the correct SMV projection, right? Well, what you want to see is you want to make sure that the mandibular rami are not superimposed into the mastoid area. Okay, so this mastoid area is here, and here are the mandibular rami, right? So we want to make sure that those mandibular condyles, and that's exactly what it is, the mandibular condyles are not superimposed over that area. So pay attention to this mandible, right? How is that mandible going to get superimposed over those mastoids, right? Well, if I don't have enough extension, right, because this is the proper amount of extension, you see these get cleared away from the mastoids. But if I don't have a proper amount of extension, do we have the mandible now getting superimposed over the mastoids? We sure do. And that is caused by insufficient extension, okay? But what else can cause that, right? Because what if I'm like this, right? How is my CR supposed to be in comparison to that? So if I show you this, right? My patient's like this, he can't fully extend. How should my CR be? It shouldn't be perpendicular to the IR, right? Because then this is going to cause the mandibular rami to get superimposed over the mastoids. So what we need to do is we need to make sure that our CR is perpendicular to the IOML. All right, and that'll help guarantee that these mandibles are not going to get superimposed over the mastoids. Okay, so again, should be like this with the CR coming perpendicular to the IOML. But if the patient cannot fully extend, we still don't want the CR coming straight. We want it to be angled to be perpendicular to the IOML. Okay, so two errors can cause the mandibular condyles to be superimposed over the mastoid. It's either a lack of extension or insufficient extension, excessive flexion, either way, right? Excessive flexion, insufficient extension, or your CR was not perpendicular to the IOML. Okay, so those two things can cause those mandibular condyles to be superimposed over the mastoids. All right. Here's what it looks like. All right, so again, entire skull visualized. You want to make sure that these mandibular condyles are not superimposed over those mastoids. Okay, if you see them superimposed over the mastoids, then you have excessive flexion, insufficient extension, or the CR was not perpendicular to the IOML. Okay, remember, for rotation, we're looking at the mid-sagittal plane, right? If it goes that way or that way, it's rotation. How do we determine tilt? We're looking at the distance from the mandibular rami to the lateral cranial cortex, right? So again, this is my right side, this is my left side, right? So the left side looks a little bit bigger there, right? So if that left side got bigger, what happened? We have tilt, right? But which way was it tilted? And we always look at the vertex. When we're looking at tilt, we look at the vertex. Which way was the vertex tilted? Vertex was tilted to the left. All right. And then, of course, optimal exposure factors, sharp lines, bony trabecular markings. Okay. All right. A couple things here before we end is the AP versus PA projection. Right now, when you're looking at these two radiographs, right, they're both 15-degree angles or Caldwell projections, right, because they're in the lower 1/3. One's AP, one's PA. How can you tell? Well, remember, when we're doing a PA projection, the orbits are close to the image receptor, right? And so if you're asking which one's AP versus PA, well, which one's AP? Right? AP is going to be A, right? And that's because the orbits are bigger, right? So you pay attention to the orbits. They got wide eyes, right? Looking at you like this, right? And that's because they're further away from the image receptor, so they're going to be magnified. This B is a PA. They're smaller. They're closer to the image receptor, less magnification. Okay, so that's how you tell PA versus AP for the orbits. All right, so let's look at some radiographs for critique. Here's the lateral skull, right? So what are the 3 repeatable errors that are present on this radiograph? Okay, so let's look at it. Right, so we see that first thing we should check for on all lateral radiographs is all the anatomy included? Yes, it is, right? The skull's there, everything's included. First error, right? We always see always no marker, right? So we know that's one of the errors in there. But what else do we check for? We check for rotation, we check for tilt. So let's check for rotation. Right? Do you see any rotation? And for rotation, what do we look for? Anybody? Anybody? We look for anterior posterior separation, right? So, and what's the first structure we look for? You should have said the mandibular rami, which are down here. So you see this line there, this line there. There's some anterior superior separation. See these 2 lines here, anterior superior separation, right? And what are those? Those are the greater wings of the sphenoid, okay? So because of that, we have some rotation, all right? So we have rotation, we have no marker, and then the last thing you should have said, right? Pretty obvious, artifacts. All right, we have some artifacts. Now for tilt, how do we check tilt? For tilt, we're checking what type of separation. Did you say superior inferior? If you did, you are correct. Now, what's the first structure we should look at for superior inferior separation? Now, if you said orbital roofs, orbital plates, you are correct again. Very good. You're doing great. That structure there, right? So if you see one going higher, one going lower, then you have tilt. Okay, but we don't have that there, right? It looks good. So the errors here should have been foreign body, which was that structure that we saw. Rotation, because we checked the rami and the greater wings, and there's no marker. So if you got all those, you are good to go. All right, let's look at these here. Which radiograph is an AP projection, A or B? All right, so again, what are we looking for AP projection? Look at those orbits, right? Sides of the orbit. So which one's A, which one's the AP projection? right? I mean, let's compare them, right? There's orbit there, and then boom, right? Wide open. So the AP projection would be B, all right? Now, let's look at B, that AP projection. What positioning error, if any, are present? It's supposed to be a Caldwell. Okay, so obviously no marker, right? We know there's no marker, so don't worry about that. We already know that. But with a Caldwell projection, what should you see on a radiograph to let you know that it is a 15-degree Caldwell projection? Right? I hope you said the ridges in the lower 1/3 of the orbit. And if you did, great. Are they in the lower 1/3? No. They are too low, right? So now here we go. What's going to cause those ridges to go lower in the orbit? Again, pay attention, right? Remember these, they're supposed to be here. So how can I get them to go lower? If I have excessive extension, they go lower, right? And if it's excessive extension, kind of partner that with excessive angle. Okay, so excessive extension, excessive angle. So too much angle or too much extension. All right, so Petries ridge is not in the lower 1/3. All right, and oops, we're still talking about rotation too, but I got too excited talking about the angle. I mean the ridges. So there is rotation, right? And how do we check rotation? The distance between the lateral orbital margin, lateral cranial cortex. Right? One side's bigger, right? So remember, this is the right side, this is the left side. The right side has more distance between the lateral orbital margin and the lateral cranial cortex. So what does that tell us about rotation? That means the face was rotated which way? To the left. Okay? Let's go back real quick. So again, Petries ridge is not in the lower 1/3, right? And that is caused by either excessive extension or excessive angle, right? Now this could also be, just remember, insufficient flexion. Okay, so they didn't flex enough. They had too much extension. Okay. Hopefully this is helping you kind of understand it. I mean, I'd rather do this in person, but you know, we can't, so. All right. Lateral skull. What are the errors present on this lateral skull? All right. So let's look at it. First of all, is all the anatomy there? I mean, we're kind of close here, right? So we may say get a little bit cut off there, right? What about rotation and tilt, right? Again, how do we check rotation? Looking for what type of separation? Anterior, posterior. What's the first thing we check? Mandibular rami. See a line back there, a line back there. There are two rami. So that means that there is rotation, right? Also, if you look here, there is one EAM. There's the other one. One in front of the other, anterior, posterior separation. We have rotation. Right, now let's check for tilt. What's the first thing we check for tilt? And you should have said orbital plates or orbital roofs. Do we see two lines? We do. So what does that tell us? That there is superior and inferior separation. There is tilt. Also, if you look at the EAMs, one is sitting higher than the other. So you have tilt. Okay. Now, so we have rotation, we have tilt. Obvious, right? Might have cut off the anatomy there. No marker. Right, what else? Now, if you're saying foreign body or foreign substance, there is foreign substance or foreign bodies in there, but they are part of the procedure that was done to the patient. So this here is a tube kind of used to help relieve fluid or pressure inside the brain, okay? And then here are some hardware that has helped to hold the skull in place. You can tell that it was either opened on purpose or cracked, right? Because there's lines there. Right, tells you that it was opened up, so they might have done it to have to do some surgery in there. So they use those to hold it back in place. Okay, and that there is a catheter just to help remove some fluid or something in there. Okay, now there's one other error on there we haven't talked about. Got rotation, got tilt, but remember that rotation and tilt. How do we get a true lateral position? There are four things we have to remember, right? We have to make sure that the MSP, mid-sagittal plane, is parallel to the image receptor. We have to make sure that the IPL the interpupillary line, is perpendicular to the image receptor. We have to make sure that the IOML is perpendicular to the front edge of the image receptor. And then we have to make sure that the GAL is parallel to the front edge. Well, let's look at the IOML. Is that perpendicular to this front edge? It is not. It's got too much flexion, right? Also, if we look at the GAL should be parallel to that. It's not, because there's too much flexion. All right, so that was the last error. You got anatomy cutoff, which is up top, too much flexion, right? Tilt of the orbital plates, rotation, and then of course, no marker, right? All right, PA skull. Which PA skull projection is this, first of all? All right, well, whenever we're looking at PAs, right, we're gonna look at relationship of the orbit and the Petrus ridges, right, Petrus pyramids. So what do you see on this one? The ridges are in the lower 1/3, right? So what does that tell you? It is a Caldwell projection, all right? Now, what are the errors, if any, right? It looks like they're in the lower 1/3, so I'm okay with this projection here, right? They're almost 1/2, but it's still lower 1/3, so I'm okay with the amount of angle there, so that's fine. But what other errors do we see? Well, we see marker there, right? They actually put a marker on this one, just they put it in the anatomy, which shouldn't be there, right? Then this here, right? So this here was old school patient information. So we would have like a little area where there would be patient information, name, date of birth, all that stuff. That normally would be down here out of the way. So they put it in the wrong area, part of the skull. So that's in the way. And then the last thing we can check for is rotation, right? How do we check rotation? Lateral orbital margin to the lateral cranial cortex, right? Does it look the same? I think it looks almost the same. You know, there might be a little slight rotation, but it's not anything that would cause for a repeat. Okay, so main things are marker, this thing up here, and I believe that was it. Marker placement, patient ID marker. Yep. Oops, let me go back, erase that stuff. All right. Almost done here, guys. I know it's been a kind of a long, PowerPoint presentation, but I kind of wanted to go over a lot of things a lot of times just so you can get familiar with it. So as we move on, it won't take as long. All right, the midline point at the junction of the upper lip and the nasal septum. So upper lip, nasal septum. What is that called? 3, 2, 1. It is the acanthion. Very good. All right, point me out. Where is the nasion? Just said here. Glabella, between the eyebrows. Mentum, chin. Good. There is a blank difference between the orbital meatal and infraorbital meatal lines. 3, 2, 1, 7 to 8 degrees. How much CR angle is required for the apiaxial projection of the skull if the IOML is perpendicular to the IR? So this is the very first projection we learned about, the town. Remember, we had to flex the head, bring the OML perpendicular, and then we angled a certain amount, right? If we couldn't use the OML, we used the IOML, and we had to increase the angle. What did we increase it to? 3, 2, 1, 37 degrees. So it's 30 degrees with the OML perpendicular, 37 with the IOML. Which positioning error is present if orbital plates are not superimposed? You have superior inferior separation on a lateral skull radiograph. So remember, anytime you have inferior superior separation, that means that you had, right, here's my skull and a true lateral, right? If I have inferior superior separation, that means that I had tilt of the skull, right? Not rotation, but tilt. Good. Which variation of the PA projection of the skull has been performed if the Petrus ridges are at the level of the supraorbital margin? Okay, so again, Petrus ridges are at the supraorbital margin. That means they're way up here. So the ridges are filling the orbit. Which projection would get us where the ridges fill the orbit? 3, 2, 1. PA 0 degree, right? In the PA 0 degree, the CR is parallel to the OML. If the CR is parallel to the OML, the ridges will always fill the orbit. Keep that in mind as a kind of a baseline. If the CR is parallel to the OML, there's no angle between them, the ridges will fill the orbits. Okay. PA 15 degree, where do they go? Lower 1/3. PA 25 to 30, below the orbits. All right. Which positioning error is present if the mandibular condyles are seen within the petrous portion of the temporal bone on an SMV projection? Remember, petrous portion hold the mastoid area. So if you see the mandibular condyles in that petrous portion or the mastoid area, what happened? Okay, here is my normal SMV. Here are my mandibular condyles, right? Here's my petrous portion. If they're located in the petrous portion, what happened? I either had excessive flexion, insufficient extension, or what else could have happened? The CR was not perpendicular to the IOML. Okay, but on this answer here would be insufficient extension. Okay, insufficient extension. But it could also be, that's it, insufficient extension. Now, you won't see both those answers like insufficient extension or CR not perpendicular to the IOML. It'll be one or the other. But the best answer here would be insufficient extension. You could make a case for incorrect CR angle because the CR needs to be perpendicular to the IOML. But the best answer here would be insufficient extension. All right. That is it, guys. If you have any questions, let me know. Send me an email. We can talk about it during a lab on Tuesday or Thursday. But make sure you look over this because the projections that you will be doing for the lab will be from this lecture. So make sure you look on the module for the lab room assignments. I've put up the schedule already and the projections that you will be doing. PowerPoints are up, so I'll put this up as soon as it's available to me. So you watch this video. And if you have any questions, again, email me or we can talk in lab if you have any questions. Okay, guys? All right, thanks for being here. Hope y'all wasn't too much for y'all, but I'll post this as soon as it comes available. Thank you.